I think that's a really important question. So BTK inhibitors are known to have very defined cardiotoxicity profile, including hypertension, and then arrhythmias, atrial fibrillation, which I usually describe to patients as usually not life-threatening, but extremely annoying. And for anyone that treats people with AFib, it's a lot of stuff that can really increase burden of care substantially for patients. And then, of course, there's a concern about lethal ventricular arrhythmias with the approved covalent BTK inhibitors, which was seen mostly with ibrutinib. But I think if you look carefully enough, you can find that with the acalabrutinib. I haven't seen that with zanubrutinib yet, but I think the experience is still increasing. So it's really important to discuss this with patients when talking about prescribing these drugs. And I do have some patients who very much are concerned about AFib or had had atrial fibrillation that was just difficult for them in the past and really want to make sure they avoid that in the future and are really worried about the whole class of drugs because of that. Usually hypertension seems to be less of a problem unless you have someone that's already on multiple drugs for it. I usually explain to patients that the risk of these things continues to increase the longer they take it, unlike some of the other side effects such as myalgias, which tend to decrease after the first few months. So that they're like not out of the woods if they don't get it in the first 6 months, that this actually increases over time. And then, I usually pick a BTK inhibitor with a better safety profile in terms of cardiovascular risk, which would be acalabrutinib or zanubrutinib for sure. I think there's a couple strategies that can really improve this. One is fixed duration regimens with BTK inhibitors, particularly with like a BCL2 inhibitor combination. So you see the cumulative incidence of both hypertension and AFib increases over time. So if you limit the duration, you limit the exposure to the drug and the risk of patients developing this. So I definitely discuss this with patients as a strategy when I can offer them, clinical trials with a fixed duration therapy. I think the other question I'm super interested in is what we're going to see with pirtobrutinib. So far, the rates of hypertension and AFib look to be less, but the follow-up and experience with treating people is shorter. When you're looking at a drug where the median PFS is, somewhere between 1.5 to 2 years for most patients, you don't have people on the drug, 5 or 6 years at this point. One, it hasn't been around that long, and two, if it doesn't work that long, people won't take it as long. So I expect that as pirtobrutinib, which is of course a non-covalent BTK inhibitor and very selective, is used maybe earlier in the disease course, we'll get to see more follow-up with that and maybe get a better handle on if there's any cardiotoxicity there that we're seeing. So I'm really excited to see how this plays out. And I think it's definitely individualized for the patient, how important it is for them as an individual to avoid any cardiotoxicity based on their cardiac risk features and, of course, history of cardiac problems. And then also how can we minimize it using some of these strategies of more selective drugs or fixed duration treatments.